So this is one that I would recommend to you. It's good, it's concise, and you can download it for free at this address. And it's from 2006, and it shows you another thing that's very important. There's little progress in this field because there's a big lack of good research done. So I'm going to talk, we don't have much time, I could talk a whole day on that, but I'm going to talk you through some of the things, and we can discuss later on. You can talk to me all the time through the conference on special questions and problems that you have experienced. Blood pressure is maybe the most worst thing that you have to look for. It starts with hypertension when the patient is herniating. It's not of long duration, this hypertension, but it's critical because in this situation you can have myocardial infarction. It was shown that the myocardium has necrosis in there after this situation, so you might as well use short-acting beta blockers in this situation to cut this off, to treat this. If you use something longer-acting, you might come into big trouble because as soon as this herniation process, this storm, as it's called, is over, then you have the situation of vasodilation and also of an increased permeability of the endothelium, and with a resulting hypervolemia, and you get hypertension. This is then also even more pronounced when you have diabetes insipidus, because then you have an even higher hypervolemia. So in this situation, you will need to increase blood pressure. First goal, what you have to do is normal volemia. Most of these patients are, almost all of these patients are hypervolemic. Why? They had maybe treatment for increased cerebral pressure, so they had diuretics, they have the vasoplegia, they have the increased permeability, and of course insipidus. So, if you, I'm so faster than my slides. When you're not able to manage a good stable blood pressure with volume alone, then you have to take a choice of a vasodilator. It's always been the big discussion, what is the optimal drug for an organ donor, and traditionally it was, most centers use dopamine. Dopamine is not a good drug because it has also a pronounced effect on the heart. I won't go into much details, but it's just put it in the second line. It's much better to use a pure vasoconstrictor. Why? Why the main problem is the vasodilation. Why? Because you can, because you don't increase the oxygen consumption in the heart, especially, which is a very important thing. So use a vasodilator. You have, excuse me, no problem with splanchnic perfusion. That was very well shown for norepinephrine, but also for vasopressin. And vasopressin is in many guidelines now the drug of first choice, because you can have it as well for the diabetes insipidus as also for the hypertension. You treat the symptom and the cause with one drug. Only if you see that if you have proof that the myocardium is failing, then you should go to an inotropic drug like dopamine or dobutamine. In this case, but you should also have a good monitoring to keep you really on line what's happening to the heart and to the hemodynamics. In many guidelines, still the pulmonary artery catheter, the monitoring device that is put on the first line. We have so many non-invasive cardiac output measurements that I would not recommend to use the PAC right away. It's also in the Canadian guidelines. It's suggested that you use it when the ejection fraction of the heart is below 40%. But either you check your patient with transesophageal echocardiography, which would be the best, or with some non-invasive device. Don't forget all the problems you can have with a PIC. Don't forget the hygienic problems you have with a PIC. And non-invasive, you skip all that and you have maybe the same good results. Next problem, metabolic problems. Glycemia and nutrition. Hyperglycemia is something that occurs very often. There's been an awful lot of discussion about the detrimental effects of hyperglycemia. All of you who work in the ICU have known this discussion from all the critical care patients, that we should induce normoglycemia, that we should use high doses of insulin. This was also suggested for donor maintenance, but be careful about that, especially not to levels that would be recommended for critical care patients. It's not going to last that long, this period of donor maintenance, that you would have to worry about high glucose. You don't want the patient going into diabetic coma, of course, on donor to go into a diabetic coma, but it's a situation where you're treating more the osmolarity of your patient's serum osmolarity, and which can aggravate the high osmolarity that results from diabetes insipidus, then all these factors that would be named for the treatment of the critical care patients. Enteral feeding is recommended. It's a way of keeping the gut intact and to avoid germs to come through the barrier into circulation, but no parenteral feeding. Maybe a little bit of glucose that you infuse, but that's everything. Diabetes insipidus is in 80% of your patients. It's not always when the patient has a high urinary output, it's a diabetes insipidus. Be careful about that. You only talk about the diabetes insipidus when you have a high urinary output for more than 4 milliliters per kilogram body weight per hour. You have a high serum sodium and a high serum osmolarity and a low urine osmolarity. In this way, you can really say that, okay, we have diabetes insipidus. We make specific treatment, and specific treatment means that you look at the cause, which is the lack of vasopressin due to the failure of the pituitary gland, of the posterior pituitary gland, and in this way, you can give a specific treatment. Vasopressin in continuous infusion should always stay below this 2.4 units per hour. DDAVP is a synthetic vasopressin which has no effect on the receptors for the vasoconstriction. So if the patient has a good high blood pressure, you could use that, and you're treating only the diabetes insipidus. Hypernatremia can be a very severe problem. With a sodium above 155, you're talking about hypernatremia. It has to be corrected because it was well shown that that high sodium levels are associated with hepatic dysfunction and also with graft loss. These livers are really bad in the recipients. So you correct that, but you don't forget about the other electrolytes. Potassium and calcium are very important because the final cause for brain death, not donors, because these were patients in Japan mostly, where organ donation was not allowed, and they had to keep brain dead patients going for 20 days and longer, and the cause for final cardiac arrest in these patients were always arrhythmias. So this is the point where you finally cannot go on when the arrhythmias start. And this is one of the most important things, that you keep the electrolytes in a good shape to avoid this. since I'm working in this topic, there's the discussion, should hormonal therapy be made in organ donors? It was the discussion about methylprednisolone, about insulin, and also about phyronin. It was shown that hemodynamically unstable donors could be transferred to donors which are which can be harvested, but there is no real convincing evidence. So Yunus made a big trial and suggested that it doesn't harm and it might be of benefit, so you should use it. And you're looking at the Yunus guidelines. In other guidelines, it's not prominent in the treatment. This would be the scheme of substitution that would be recommended in the Yunus guidelines. But all of that, when you look at these guidelines I've presented to you that you can download from the internet, you have all these numbers in there. Should I transfuse a donor? That's always a question because, of course, you have increased risk of transmitting diseases with transfusions. It's expensive to transfuse. And still, organ perfusion and oxygen delivery is a big topic. That's what you're actually doing. You want to optimize the donor organs. So you should take care of hemoglobin content. However, usually it was said you should keep it up to 9 to 10, but it's generally in critical care that you accept now lower levels, and it's quite acceptable also in an organ donor that we know nothing happens, nothing worsens if you let the hemoglobin level drop down to 70 grams per liter. Below that, you should really transfuse. It's very important that you draw the blood for the donor serology on tissue typing before you transfuse. Don't forget that. A lot of discussion is also going on about infections and hygiene and prevention and what should we do. Daily blood cultures, mostly it is said there should be at least one blood culture when the process is started, that you know where you're starting from. You need it also for the process of seeing when is the patient really fit for, is he really a donor candidate these organs. After that, you would make it more or less on demand. And standardized prophylactic antibiotic therapy is not recommended. So you would not give empiric broad-spectrum antibiotics. But you would give antibiotics if you find some source of infection, and that would not automatically. That's always the big question. Should we resuscitate a brain-dead donor? Yes, of course. They are mostly very easily converted. Only when you come in this final stage that I told you before about, then you fail. But of course you should try, and a resuscitation in an ICU environment has a very good chance that the organs that you are looking for are still very good preserved. At least the kidneys. And you should, it might be a problem for the motivation of the team, but you should be aware and you should keep your team aware that you do not resuscitate the donor, but the organs that you are looking for and that you're working for. Okay, I'm summarizing. Still, this is a very poorly investigated part of intensive care medicine. Most recommendations are just based on expert experience, and not so much on scientific evidence. However, we see that we have a high number of success, that we have increasing numbers of donors which are transferable into real donors where you can harvest the organs. And we see that this process is also accompanied by improved graft and patient survival. Thank you.
Thank you, Dr. Fitzgerald. Any questions before we go to lunch and prayers? Any questions? Okay, we'll meet here at 1:30 sharp, please, to start our next session. Thank you very much.
Well, it depends what it is. The Canadian is really good.
My own experience is the same, that rather dangerous, especially not advocate.
What they say, Canadian guidelines.
The semi guidelines are excellent. I mean, this is something very, very good.
It's disabling. You just thank you. You have to know the injection and the antibiotic. Pneumonia.
Can I try the presentation at 1:40 pounds. 1:45.
Did you get the program?
You did not get this little program here?
Where were you? Where should I go? Okay, I'll go to you.
What is?
Ich habe gestottert oder ich habe es geschafft.
التصويت ما شاء الله عليك. الله يعطيك العافيه. Edmond, check the translation if it's on. ايه please. شوف هالفلبيني كسوق. عبد الغيوم يقول راح. سالت انا قال انه هربت وين راحت. عليك هذا الكلام. لا جزاك الله خير يمكن هالفلبيني راح اشوف. بارك الله فيك. احنا المحاضره الى شو الى الساعه كم؟ 5 هذه المحاضرات بعدين بعد الوقت وين هنا حسب الحجم زاد كثير مقدمين عليها بركة والله شغلنا الله تنصحي مو بتعزلك نطلب منك لا تكرم بارك الله فيك الله يبارك
Good afternoon, everybody. Sorry for the delay. We don't know who closed the room during our absence. Anyway, we'll start with Dr. Abdul Qayoum. You saw him this morning. He's going to give two talks. In fact, one, how to break the bad news to the family of the deceased donor, and the second is about obstacles. He will combine them together, and he will try to go fast so we can catch up with the rest of the speakers. Dr. Abdul Qayoum.
You put it, breaking bad news, wasn't it? You put it already. You put it outside. You put it outside. Yes, yes. And I want it to be like that, in the way. Okay, thank you very much. Welcome back. I feel that when everybody is at his carbohydrates and proteins, you feel sleepy. So I'll try to wake you up, okay? And I will be short, and although I was about to give a film. But anyhow, my talk is going about the breaking bad news, and which is an important issue because the Fitzgerald is going to talk about how to approach. So before you approach, you know how to break the news. What is the meaning of breaking? Breaking means what? This is it. But the news, when I hear in the television that there is a breaking news and it gives me a news about Baghdad or Syria, is it the same breaking news which you are talking about? I doubt. Anyhow, in the past, the news used to come like this, but things have changed since the envelope came, and then newspaper, and then television, and people want to talk, and the best one to convey or transmit the news, the fast man is the females. Our females, they're the best one to give the news. They're very quick and give any news to anyone and you will spread. I'm sorry, but my wife is a girl. My daughter is also a girl. So they're all like that. Lately, of course, the best to convey the news is this. Now the news could be, in short, daily situation, exam, work, relationship, divorce, departure, accident, whatsoever, serious condition. And this could be generate a more or less unconstricted response, a bad response. Now, quickly we go the way to convey the news, that either to tell somebody that there is good news that you have a baby, and you wait for a silence, and with the bad news that you lost the baby. Or you could say that good news is the results out, and they start again. I wanted to say that there ought to be a way to give that news. So why conveying the bad news or deliver the bad message is difficult. So we have to pick a proper time for that news, and proper place, and proper person to talk to, and a way to talk should be important. You cannot just sit and talk with an elderly man like that. There ought to be a way that to give the news, very important. So you have to select the proper and to have a wisdom in breaking the news. Okay, and that is very important. Actually, it is in a skillfulness for some people how to break the news. Now, let us talk. Our main issue is why the medical professionals, they are afraid of breaking the news. Why all of us? It's a very difficult task, as one of the Jadda told me, that I am really hesitant to give the news because I am a treating doctor. I don't want to give the news for to those whom I had been treating their beloved for a good time. I tell them that he's dead. I keep away. Somebody has to do it. So I requested him. He was supposed to. So why are the medical professionals are afraid of conveying the bad news? The reason could be that fear of self-guilt, and this is a problem that they are emotionally demanding. They are afraid to give the news, or because the professionals feel trapped between need for the bed and nothing to offer to the bereaved. It's true that most of the doctors, they want to treat the patient, but they need the bed and they want also the organs. So they are hesitant not to give the news again. And crucial factors that just like consider the relative grief. He's afraid that when he tells the news, the relative will have a shock and he will feel self-guilty. Or the repetition of the medical staff and the hospital. As some they said that if we keep giving you organs and brain death cases, then people will say that these hospitals, it is known that if you be admitted in the hospital, they will take your organs. So he's afraid of his hospital and his own repetition. That is why they are hesitant. Or some do not know how to do it. As I said, he doesn't know how to convey the news. So he leaves it for his colleague. So this is why we, as the medical professions, are afraid. Or, as I said, some do not have, or they are afraid that the family reaction, as we said it, that he is afraid of the family reaction, he keep away from them. Now, who should break the news about the potential disease donor? These are very important questions. And since all the doctors are hesitant, so who should do it? Is it direct or indirect? Indirect, you find in the hospital a lot of paramedics. They keep on telling the bereaved, the families that your son or whoever is he lost brain death, and there is organ donation, and that will upset our program. Medics, paramedics, and or a wise man in the family. But directly a doctor, a treating doctor should, a nurse, sometimes they do, and social workers, they do convey the news. But we have to select a proper man, proper skillful man to convey that news. Regardless of any brain death, is it not a duty or of a doctor to convey the news? This is an important question. So if this is duty, then he has to convey it, he has to say it. In respect of anything, he has to give the news of the situation. So where to break the bad news in a potential case, in a appropriate time, as I said, is it abruptly or gradually, which way you want it? You just cannot tell somebody that you lost your son, he died, sorry. As people outside say that I'm sorry that you lost your son. No, you have to give gradually because you're afraid of the reaction. Or you want to give it in days, we don't want to give it days because we are running against the current. We want to gain time, the patient will be lost at any time, his brain death, so you don't have to give it in days. But still, the loss of the donor or long stay in the ICU is not good for us and not good for the family because of the agony of the family. So we are again pulling two sides. So now, terminology used, that you have to select a good terminology. I wish to, I'm afraid to. That term was given by Dr. Al-Ghawi in the morning. He gave a nice term in one of his slides, the way to give the news. You cannot tell it that seriously. He is not. He is confusion. No. He has to tell them that he sustained an irreversible brain damage once you diagnose the case. Now, not to use unclear terms, as I said, seriously ill or comatose. He is not comatose, he is not vegetative stage, and he is brain dead. Well, you have to have a good way. By time, you learn how to give that news. Okay. Now, the importance of breaking that bad news is that to avoid worsening of the grief response of the family, and the family could absorb the shock. Give them a time, they absorb the shock, and somebody will tell them about the organ donation. Or give the family enough time to think what is next. They want to switch the ventilator, they want to usually take the patient to another hospital, they want to do whatever, give them a time. But you have to be given in doses. And to prepare the family for organ donation, this is for us. We have to prepare them for that. That is why we are talking breaking news. And now, the grief response of what will happen when you tell some people like that. I was about to give a film about a doctor who is giving a talk quickly to a patient who has CA, and the patient's keeping listening, and the doctor said, I'm busy, I have to go. And he did not give the message, but I'm sorry because we're running short of time. So what will happen? What will happen to the grief response? That the grief is very personal experience, and each individual will react in a different way. That we know it all. Now, loss of the separation invoke a powerful and sometimes bad feeling, conflicting emotions. You have to be prepared for that also. And what will happen to them then? A brief response could be anger, denial, and panic, acceptance, confusion, anxiety, and suspicion. They suspect that, well, you killed my son, you killed my daughter. So they go and complain. You didn't give them a wrong drug. They will keep telling you this. And all, they have a fear, resignations, fear, resentment, and hope. They may hope. They will tell, I'll bring a sheikh, a biased man, to give and read on him, and he'll be all right. That will happen. That is the reaction of the bereaved. But that reaction is happening because of what? A response depends on a manner in which you give the information. If you just tell them that abruptly, the response will be difficult. Cold, you tell them unclear, so you have to be very clear for them. So the response of the bereaved relatives would depend on the way you convey the news. And more than 2 families in one accident, the response will be great also. 3 families were lost in one car accident, or a precious baby, or cause of death itself, car accident. Sudden, the boy here, he was in the house and he said, I'm going here, nearby and coming, and the news came that he died. So it depends on the situation of the cause of death, or the age of the patient, a young boy, single in the family. That all factors which give a response of the grief, bad or very bad, or they may be accepted. Where the conflict between the medical professionals in giving the news, one doctor may say that he's still not brain dead, and the other will say, no, I'm sure that he's brain dead. No, we have to make another investigation. No, we have done the investigation. So when the family hear these conflicts, they will have very bad response, and they will not trust the hospital. Okay, and what about the medical professional response? What about our response? We have to have an sympathy with the family, especially if there's a bad events, shows social events, as I said, 2 or 3 families in one accident. We have to create an atmosphere and confidence with them, which is very important. Since we have been treating their bereaved, we have to be with sympathy with them, sit with them and create a good atmosphere with them. And we need to respond immediately with psychological support and help them alleviate the tension. We have to be with them, not against. We have to be with them. We said, don't just tell them the news and fly away. That will be a bad response to them. Doctors also should explore their own feeling to the bereaved. I'm sorry, I'm deeply sorry. I wish I could have done something. I heard some doctor said, what can I do for you? I decided my best. It is not the way to. You have to be a condolence to them, give them the condolence. May God rest his soul in peace. If you wear that, will give them that you are really supporting the family. A good explanation of the medical situation. You cannot just tell them, show them the EEG or show them the carotid angiography, no. But tell them the situation, how he died. He sustained a brain damage and the brain supply cut to the brain, and all these few terms, you have to get in a good explanation. All medical support should have been done. Tell them that we have done our best, and we could do nothing. And conclusion, I'm trying to be fast because we are running short of time. Our conclusion is the good message should be very proper, in a very proper way, in a good way. Nurses and social workers, they play a big role in that. They play an important role in increasing the pool of organ donation only by conveying the good message. Very important message. So, thus, the success of coordinators in obtaining consent depends largely on how message is delivered to the family. And that is why the topic came to breaking news. So since I have been talking about bad things and bad news, in the end 2 minutes I will give you nice slides to end it. And that will be the end of my talk, and thank you very much. Enjoy your conference. Okay, continue, or do you want any shortcut to eyes?
I think if you continue with the obstacles to organ donation, in short, before
Somebody will
before
forget
the
his
next
question
speaker.
then.
No.
Any question?
Any questions about passing the
eyes.
bad news to the family? Any concerns?
No question. Thanks,
Okay,
God.
so proceed with the next
Thanks, God.
next talk.
Katua, I don't have a question.
If you remember, that is the old question for the last year. Let me repeat it again. Doctor, do you
Let's
think
repeat.
if we are going to educate the residents and people who is living in our kingdom regarding the brain death, and we take them to the high level of understanding that situation, this will solve some problem we face it
Certainly.
regarding
Certainly.
importing them regarding the brain death, how come to convince them first that it's a brain death, then another convince for donation. But do you think if we educate them well, even if they don't have them, do you think this will save some time for us?
It does. It will, inshallah. And that will be next year, this one. Obstacles. And when you talk about the obstacles, I will mention that. And awareness of the doctors, awareness of the public, and these are the important things to talk about. Then we'll talk about the obstacles. The question is there any obstacles? Is there any growing gap between organ supply and demand or not? Is there any? There is. Thank you very much. So there is. We admit that there is a growing gap. So if there is a growing gap, is there any sufficient number of potential donors? Practically speaking, we don't have sufficient number of organ donation. Do we have? Our waiting list is more than 4,000, and we are transplanting 400, 500 per year. So we are really running short of organ donation. So if the answer is this, in the hospital, the Kingdom of Saudi Arabia, deceased donors, total hospital OH in this number, and the estimated brain death is 9,850, and while the brain deaths which we are receiving in this number. So where is the other numbers? Where are they? Why we are not receiving the calls? Why are not getting the numbers? What is the source of that? Our source is, I'm sorry, there was, no, this is the sources of the major cause, the major source, road traffic accidents. So there is more than 4,000 fatal accident. Maybe with Sahir the number now is reduced. And finally, we are estimating that 40% of them, they are stated and admitted in the ICU, and less than that are called to Scott. We are receiving 400, 450. Now the number is increasing, 500, by our awareness of the doctors. So I give this to tell that really there is a gap. This is that the two previous slides were a study conducted in Scott by our colleagues, and the net result is this possible is 850. See, now the gap between the actual, which has been harvested, and the consented one, big gap. And the gap between the possible and eligible, and the gap between consented and eligible, and the gap between consented and actual. So there is a big gap between all, so we are really shorted. So where is the obstacles? Is there any really obstacles that we are facing, and where is it? And who is the obstacles? Who? Is that me, you, all of us? And where is it? And what is the obstacle? When shall we deal with it? How to deal with it? And all these questions, and I don't know who we can claim to, or whom can we blame. Practically speaking, we are Scott responsible of all this. We are studying all these things to solve it together. Practically, we have two issues, major issue. The medical diagnosis, which had been talked in the morning, and the legal diagnosis, which Dr. Qayoum talked about. These are not the major. They are not obstacles, all of them. But if we talk about the obstacles, let us be frank. And if I am mistaken, correct me. One of the major hospital in the one of the obstacles is donor hospital, where the local authorities themselves, they are not helpful, or eligibility of the patient, they don't admit them, especially they expect the foreigners. Inadequate of medical staff. We are running now in this conference. We had sent to more than 300 hospitals. Most of them, they said that we are running short of staff. Unclear policy for the hospital, and we talked about that. There is some unclear policy. Diagnostic setting, EEG, carotid angiogram, not available. And cooperative staff, director, OR, laboratories, virology, toxicology, invasive and non-invasive investigation, all, some of them, some hospital, especially the remote one, not available. Now, what about the other obstacles which we are facing? Late recognition, hesitance, knowledge of the doctors. I met some doctors, they said, I have no much idea about it. I don't know how to diagnose brain disease. He is escaping away from the city. He doesn't want. His senior colleague told him not to get involved in this. Keep away. It creates problem for you. So he doesn't want to. Dependence of the others, responsibility towards the others. Shortage of bed. This is a big problem which we are facing. Transferring a donor to intermediate ward. A lot of hospitals now, they have an intermediate ward, then they diagnose the patient, Scott did not reply for them, no communication between them, then they transfer the patient to intermediate down step ward. And this is practical happening to your hospital. We transfer the patient down, neglect him, no news. Now the other medical, which is very important, and these are the main issue which we are going to talk about, the late reporting. Why there is late reporting, I don't know. Answer one of you will give me. And miscommunication and miscoordination between Scott and ICU, and cooperation between staff also. Wrong message to the family, which we talk about, and disappointment. Some doctors are very disappointed because of had been treating the patient for a long time, and outcome was bad, or we could not retrieve through two reasons. Or he lost the patient because he had been trying with him, or because we did not retrieve, because for the reason or another which we are going to talk about. Feeling of health professionals toward an organ donor. Some people feel CNBC, young boy or girl, we are not going to the child, let her go in peace, like that. They used to tell that. So personal failure. Some doctor, they said, well, I had been trying for a week, and my fault. I should have given this, I should have done that. So he feel bad that, well, I should not talk about organ donation because our mistakes. Now diagnosis, delay in diagnosis, inadequate protocol, and this is very important. I noticed that some people, they start by apnea and then jump to the first test. Our protocol is to start with first test, EEG, second test, and finally apnea and documentary of diagnosis, which Dr. Qayoum talked about. So this is very important. One of my colleagues also said, once I go to the ICU, the first thing in the morning I do, I just make a small apnea and see whether the patient is alive or not. Small apnea. There is no big apnea and a small apnea. It is one, and it's done once, not twice or thrice. He cannot do every day and go and check and test for the apnea. So failure of the apnea is a problem. A lot of colleagues also, it fails once, you forget about the case. Why should you? There ought to be a reason for the failure. Either there is a cardiac problem or chest problem which causes his failure of the apnea. So he has to go on. Bad maintenance is very important. We had a talk with Dr. Robert about the maintenance is important. There is no sense giving me a case without maintenance. What is the use then? Bad perfusion, bad everything. So don't call me. If once you call me and since you made the diagnosis, then you have to maintain. You have to give you a good eye till we come to retrieve. So no sense of giving a call without maintaining. You have a treating doctor, you have to keep your eye on the donor till it is either the cardiac arrest took place or harvested. Now, we have been talking about the failure of all medical professionals. No, but we should not blame them. All of us should not blame each other, because there is another causes of our failure, that they may be arrested. About 42% of them, they may be arrested in 24 hours, according to our studies. Arrest within 48 hours also, good number, 25%. Or documented and we could not complete documentation, also good number, we have 32 numbers. So all these, we don't have to all to blame the doctors and the professionals. These are the causes which failure of to complete documentation. So we could not complete it because patient was arrested for a reason or another. So we don't have to only blame the professions. This again will show you the difference between the actual consented eligible and potential impossible. Now, is there any problem, other problems which other centers or other organizations playing role? I said that to me that the transplant center, they also play a big role. Where? Why the transplant center? Sometimes you don't find a surgeon available. You give them an organ, give them a kidney. Well, sorry, you don't have a tissue typist, tissue typing today. We don't have a test. Well, we don't have a surgeon available. They accept the patient offer, and then to tell you that, please, could you reduce the sodium of the donor? The sodium is very high. We need to reduce the sodium. So we keep on treating the patient, and we lose the donors. Suitability of the donor, as I said, that they may be unfit. And multi-organ retrieval, that will major obstruction to us. One of the major obstruction to us was multi-organ retrieval, where two centers together, they want cardiac people, they want to have a case, and lung people, they want to do a channel test. So we wait for the channel people, or the recipient did not reach from a certain city, so we keep waiting till we lose the donors. This is one of the causes of the loss of the donors. So multi-organ retriever and recipient availability. We don't find recipients, or miscoordination between Scotland as a transplant center. Donor hospital, as I said in the early slides, could be a reason to lose the donors. Transplant center is Scott. We could be blamed also as Scott for miscoordination, but we are doing our best, and if we are blamed, we are sorry. Now, is there another reason? These are the failure, call to retrieve the organs. Unknown address, we face that a lot. And family refusal, 43%. And we come to the consented, only 10%. We are working on that. Now, is there any... Now, Saleh came and the obstacles came, and the two Saleh together. Are the administrative coordinators and obstacles? I'm going telling, because we have here, not the doctor do not involve in getting organs. So we have medical coordinator and administrative coordinator. Administrative coordinator, they are responsible of getting organs, interviewing the family. So are they obstacles also? Well, availability of the administrative coordinator in the certain area. Some of them that they in there. Are they well trained or not? Some they are trained, and some they are not. They don't know how to communicate with the family. Unknown family address is a big problem. A lot of SPACT, from the SPACT rate, they don't have family address. And family response for social events. Also, it obstructs Saleh and his group for getting the consent. Language and strategy used, skillfulness of talk. If he talked to him in a corridor or talked to him in a closed room or a director room, is different than talking in front of the patient asking for organ donation. One should not do that. Take him in a place where he could have a glass of water and ask for organ donation. But my question is always, is it an interview or is it approach or convincing? That she is going to talk about it in the next lecture. Is it an interview or this discussion or something else? And language use and Medivac. We have a Medivac capability, and the weather sometimes it becomes an obstacle for us to donate. These are the consented and obtained, and the total is gap different between the three. Okay. Now, is the religious or the leaders or scholars had been an obstacle to us or not? They gave an approval, but still the talk which we had in the morning about the conflicts which we had, dialogue about whether when to lift the machine and when to sign the brandes, it needs to be clear for everybody. A policy should be issued. Legal and scholar of Islam, they give their approval, already finished. But some of them, most of the family, they go to a leader and ask him, is it halal or haram? Is it prohibited or not? And the question will be, no, it is prohibited in some of them. So we need to meet with them, try to convince them and tell them that which is of already high jurisprudence give. You have already given your view and it's over. So sometimes they go, especially the small mosque where the people go and ask their imam, is it Is it halal or haram? So that's one of the obstacles. Now the media and the press. I believe that they are women of two ages. Sometimes they do publish nice articles like that, and sometimes they confuse us, and it happens that when that small article تشخيص about that topic stopped our program for months or 6 months. They said this is cardiac and not brain death. So that stopped our program for a month or 2 or 3 till we publish ourselves our view to the same newspaper. So the media could help us and sometimes could stop us or anything. Now the public themselves, from where are we getting the consent? Yes, from where are we getting the consent? Getting the consent from the family. Public themselves, they refuse of the concept of the brain death itself. They don't believe in brain death. Or refusal of organ donation. Or they're worried about physical mutilation. So somebody needs to tell them that there is no mutilation. Or the conflict among the family. The mother refused and the father agreed. And usually it happens. Usually. Father comes to that, I agreed for the consent. I believe in organ donation. But the mother refused. Or the elder brother said no. So they give you an excuse that they will do not. So we need really largely awareness of the public. In large, we have to talk about that. Well, now, as I said, I am being fast for the short of time. Our conclusion is the solution. My conclusion is to identify the actual problem, removal of the obstacles, early recognition, early diagnosis, more work on the transplant center. They have to work on their own affiliated hospitals, the public awareness, incentive. Some they believe in it and some do not. But I believe it is an extra job. And it is an extra job. It is a burden to you. We have to give you an incentive. Why incentive? Why not? No. We have to improve the ER and we have to improve the ICU. And we created a new program here in Saudi Arabia, the mobile team, or a key person in each hospital. I believe in the key person because that key person will be in touch with him all the time. Or the mobile team, they go and fish around for the organs and get you the organs. That was very successful in Riyadh, was very successful in Dammam, and that could improve our work. Now, difficulties or obstacles really arise in a given effect, a given case. I found in my experience, each case different from the others. In each case, it really different. It has its test. So different problems, you have to solve it differently. It is not like that. Not the same, not as the same problem. Our colleague in the transplant center, our coordinators, they look at the problem from their own angle. Plan, corneal plan, whatever, transfer plan. But let us look at all things from all different places. And we really solve our problem if we look at it from all places. And we agree upon the standardized allocation system in our transplant center because we have 13 transplant centers here. So that's why we are together in a very good inconsistency. Well, we are all have our own weakness, but there is a strength. If there is a strength, we can defeat that weakness. And we will have impact on our practice, and that will reflect in our donor rate. I believe so. And it is, I took that slide from the Dammam people. It is the teamwork. We have to work together to do not only Scott, not only the ICU. We have to work all together to make the successful program. We'll pray for you. You pray for us. And thank you very much.
Thank you, Dr. Abdul Qayoum. Any questions? Yes.
Could you please explain what do you mean by failure of apnea?
Yeah, my doctor may say that I could not. I tried the apnea 2 times. I failed to do it. And he missed that he's having pneumothorax or cardiac problem, and CO2 could not be raised.
Okay, in such a case, can you still confirm the diagnosis of brain death?
Not at all.
Okay.
Without apnea, I will not accept the case.
Thank
Although some European countries, they do go for clinical only. But according to our protocol in Saudi Arabia, apnea is mandatory.
Thank you.
Is mandatory.
Thank you.
Yes. Yes.
Doctor, you mentioned in one of your slides that 90% of the cases are not consented.
because of...
As a professional society for donation, are we going to analyze this 90%? Why is
Not 90, it could not be 90.
Let's say 60, 70, whatever.
It's okay, okay.
Okay.
Yes.
Do we going to find the reason why this percentage is not consented?
Yes, we did.
Do we
And
have that?
I mentioned it, the public and the doctors and the ICU and late recognition and late diagnosis and all these reasons given in the slides, these are all give the 60 or 70%. So
Okay. Is the mobile team is one of the reasons?
Mobile team, they did help. They did not make
Yeah, you did, but you mean what I mean? You mentioned also.
Yes.
You said in Riyadh, in Dammam, the mobile
Yes.
team are fine.
And we are waiting
What
for you to
about
create your
other,
mobile team. in
What
Jeddah.
about other areas? Jeddah, Medina, Abha, Taif.
Now we are formulating, making a team in Jeddah. You will be one of the team, and with your colleague, and I hope we will go to north and south.
Thank you.
Thank you very much. Yes, doctor.
We were talking that there is a problem if there is different centers who will harvest the organ.
Yes.
I am a thoracic surgeon in lung transplantation team in King Faisal. Sometimes one of the teams, for example, lung or liver or heart, one of the teams are not ready or the recipient is not ready. So we postpone the harvesting for 1 or 2 days. I think that should not happen. If the liver team is ready, we will put the harvesting for tonight. If the liver team is ready, it's okay. If not ready, we will go also for harvesting. They will not come. We can call another center, or if not, we will harvest the lungs and the kidneys and the heart, but not to postpone the harvesting because one team is not ready. So what you think about this idea?
Yes, I agree with you, but me as Scott, I wish that all the organ to be retrieved. I know that there is a young boy, say 16 years old, waiting for the heart, and you want to take the lung. I want the maximum organ to be retrieved.
But finally, we can lose the whole
No, I will lose. So I want to analyze the situation. That is why I said each case has its own test. So I analyze the situation, and they find that the blood pressure and the patient donor is stable. He is doing fine. I will wait for them. Otherwise, I will send you to our retrieve. It happened several times. We took only lung. Sometimes we took only kidneys, and we left other organs in Jeddah, I remember. So it depends on the situation. I studied, discussed with my colleagues in the meeting, and finally you go only for organs. We don't lose the patient. And sometimes the family will say, we want the body in the morning, 7 o'clock, we want the body. So we'll go at night at 4 o'clock in the morning and take the only kidneys. There is a lot of scenarios, if I tell you, there are a lot of things that it happens. So yes, I got my point.
Excuse me, we have to hold the questions because we have the next
the
presentation. We'll come back, we have a long workshop after 3 till 5, and we can discuss more details about the practical issues. Now we call Ms. Annalise Fitzgerald to give us her presentation about the family interview and how to conduct it.
Is it ready? Okay. Thank you. No, you have to.
It's working? Yeah. Salam alaikum, ahlan wa sahlan, and thank you very much for the invitation to speak here about a very, very sensitive part of the transplantation process. And like you said, it's teamwork. Maybe it's not only the teams of the hospital, it's also international teamwork. And I'll try to bring in all our knowledge about this topic we have. I'm working since 30 years in the field of transplantation. I am a psychologist and I am a nurse, and I am trying to concentrate on the topic of communication in this consensus. So you will see that maybe the transplantation process now people. We heard a lot about obstacles and about why it does not function and why it is very difficult to get the organs. But in this moment, you have clear that there is no hope anymore. Many families, if they get clear that there's no hope anymore, it is a very difficult moment. And a person who is losing someone, it's like the sun is falling in a black hole. And time stops. Space is different. Room is different, perception is different, and you will have maybe persons in front of you, families, who cannot react like in a normal situation, who cannot answer you in this normal way they would do it. So you have a very special situation. You have a very unusual situation, even if maybe for you it is more usual. And in this situation, you have to have a good relationship to the family, to the persons in front of you. In this situation, it is very important to give security, to give orientation, and in this situation you have to go to the basic things of communication. Can I ask who is doing family interviews? So we will work together. Yeah, and first step is to have a really clear perception. Perception, what does it mean? It means that you have to recognize the right moment. And this is not just a moment after they heard the diagnosis. You have to look at the other person and to see if this is the right moment to give information and to get information. You have to recognize if it is the right place, like we heard before, and we heard in the morning already. It is known that if you are looking for a place with privacy in a better place than the intensive care, in front of the bed, it would not be good. So you have to really be aware of these factors and how important are these factors for the family in this moment. And maybe they have enough information already. Everything is new. Everything is coming like a waterfall over the people. So you have to really to look at the other person and to see if you can give one information more or not. We are full with 7 plus minus 2. We are full of information and we cannot get any more. So this is a very important knowledge everyone who speaks with the families should have. And then it is not your duty to bring the family members more in the emotional level. So this is not helpful in this situation. You have to give them the chance to reorientate in the moment, in this place, to feel again the body, to see that there is perception from outside also, not only the grief. And the second thing is you have to look really, am I with the other person or not? You know what is rapport? Rapport is the relationship, a very good relationship to the other one. So this rapport means that you build a bridge from one human to another human and these are little things, small differences, which make the big difference. You have to look at your body posture. You have to, it is a different thing if you are standing and the other one is sitting in front of you. It is a difference if you have the same rhythm like the other person. If someone is excited, you will not come to him if you are very, very calm. You have to pick him up from one point. You have to go with him. And then it's also about the tonality, about the loudness, about the rhythm of your voice. The voice makes a big difference, how you speak with the family, and how they are prepared, and how they are going through this decision process. And the words which you create. And this is rapport. Yeah? We can see that people who are in a good communication, they are very likely each other. And without knowing that, but you can use it in this case, in this situation, because you make it easier for the other person, because you can help the other person with your body posture to feel comfortable or more comfortable. And these are very deeply based body postures or gestures. This is profound. So use it. And the third one is you have to know why I am going into this conversation. Why are you going into this interview? Do you have any idea? I want to have the organs. Then? This is sometimes a big, can be a big problem, because you should have in front of your mind that you have the chance to help someone else. You have to be the one supporting the family at the moment. Your patient is the one who is standing in front of you. The one who you have to care for is the family in this moment. So at the third point, it is to get the consent to take the organs, yes. Mm-hmm. But it's important to have all three goals in the mind, not only one. And then it's how to talk with the family. If you made a lot of thoughts in the first three things, if you did not get the rapport, the contact, if you did not have a good perception when is the right moment, or when you have to come to the other person, or what does she need. So only if you have the three other things, you can go to talk with the family. Only then it is helpful for the family if you talk with them. And if you mean pro-donation versus anti-donation, of course you have some aspects which are before already. It is like knowledge, religious aspect, like we heard today a lot. I'm going through, and fears. But we know that knowledge about the wish of the deceased is helpful, and we know that the positive attitude with transplantation is also helpful. But it is not enough. It is not enough. These are pre-request variables, but it is not enough. And it is something which is very important from the first moment in the hospital. It is the family's perceived support and the quality of care. These are key elements. So you, as the interviewer, as the transplant coordinator, you have the result of everyone who had contact before you with the patient and with the family, sorry. And so this is very well described in studies also. It is the quality of care. And what is the quality of care? It is the emotional support, which means the shown understanding, which means someone there to listen, and which means someone there if needed. And this is in the intensive care, in the ICU, so it is also outside the ICU, so, and it is in the interview, so. These are very important things, the emotional support, and the second one is the instrumental support, I have to say, is not so important. It's just to offer something to drink, to offer something, I don't know, we go over there and have a better seat or something. But informational support, and we heard that informational support about brain death has to be very clear, has to be not at the same moment when I ask for the organ donation. So it's better to separate the two things. And it has to be with clear words, like we heard before. And clear words and strategies to go through this situation for the interviewer, for the requesting person, for everyone who is working in the hospital. This needs education, this needs support, and this needs strategies. It is easier for most of us if we have a little structure how to do it. And it is easier if we can go through a difficult situation when we know first it's better to do that, after it's better to do that. Anyhow, it is always a very, how should I say, a very individual process. But if you want, I can give you some helpful points, structures. And the structures are in the focus of education of the hospital staff. Maybe millions are going to public education, but the outcome in the hospital itself, it is much more than if you invest in the public opinion. It is helpful, but I think even more helpful is to have a good education and a good program for the people who work in the hospital. So, 4 steps for an appreciate family talk. First, you have to build the bridge. And to build the bridge means why do it, why you should do it. It is to get in rapport, to get in the relationship. Yeah? And then, how you do it. This how you do it is often very, very difficult to say. People say, okay, I go in a good relationship with the other one. And then I ask, how do you do it? And it is very difficult. I don't know. And especially in a very stressful situation. So you have to know each other, to introduce yourself. And don't say, okay, I am the one who is asking you for harvesting the organs. So it should be very sensible, very sensitive. And this is exactly the wording we heard in the morning. If you just go there and say, I am here to support you, it makes a big difference. And I am here to speak with you about the next steps. It makes a big difference. And get the family to know. And you have to pick them up, to base them before you lead them to something. You have to reflect their emotions. And like we said before, you can do it with your wording, with your voice. You can show your understanding, and you can show there's someone to listen, and you can ask for needs. Is there something I can do for you now? And most of the time it is something which you can fulfill. Just a glass of water, just to sit over there. People they know you cannot bring the relative back to life. Provide security, provide calm, provide confidence. And this is not only for the family, it's also for you. And slow down helps against overexcitation, also for you. I'm sorry, I cannot go to every step. It would take more time, but if you have some ideas how to build the bridge, it's okay. And then guide to the decision process. Guiding to the decision process is also, you have to go through steps, and maybe to go some steps back and to go some steps forward. But it's just written here that you have also important is the understanding for the situation. But do not say, I understand how you feel, because you don't, normally. Say it must be difficult. Or from other families, I know it must be a very difficult situation. And enhance confidence. So here you have some steps listed, and everyone can have this structure if you want to. And you can go through by yourself. Enhance confidence means you say again, we did everything what was possible, but it did not help your relative. And then, if it's okay, if you see it is okay now, and then you can expand the view of the other one. But there are other people. And don't say people, so say if this is the son of somebody, you say there are other fathers who will lose their child or their son. And slowly you go to the question and lead the other one to this question. Let time, and you can give the view of the deceased. I don't know how your father would have decided to give someone else the gift of life. You can also say to give an organ to somebody else that he can live. And then if you take the chance to give this possibility now to another person, to someone else, we would need your decision. So what is very important is maybe compare it with other families. Compare it. It must be very difficult. I saw other families, but many times they said no at the beginning. But then when they decided to donate the organs, they felt better. They told us afterwards they felt better about that. And anyhow, it is a process where you don't have to force people. Don't force people. Let them time. And you can say 10 times, take your time, I'll come afterwards. Take your time for this decision, but I would be happy if I can come afterwards again to talk with you about that. And 55% of families make their consent, their decision, in the initial request. So sometimes this goes through the whole communication, the whole structure of this here. And the more time, this is very well known also, the more time you spend with the family, the better is the feeling and the comfort of the family. And discuss all the topics. And this is just to guide to the process. The process itself, it is not difficult. It is just one step then. But then, if you have a very good relationship, if you have everything before the decision, it is prepared already. It is the help to the family to make a good decision. But anyhow, if they say no, it is also a good decision. It is their decision. It is not yours. And you don't need the feeling, I lost. Yeah, it is up to the family. You just have to support the family to come to this point. And when families are asked after, they always say it is the compassion and the sensitivity, suggesting a convergence of informational and emotional support. So the perceived informational support means use words which people are understanding. Give adequate information, give clear answers to all the religious, ethical and cultural questions. Be with the other one, respect the decision for the family, and asking for donation is not a competition. And when you have the consent, don't go and say, okay, it's done. Stay with the family. Stay there and give them the support. Because not only for the family, not only for you, this can change the public opinion if you treat and comfort families well in this difficult situation. So structure helps against chaos. I'll stay with you. Calm and confident manner helps against anxiety. Slow down helps against overexcitation. Rational thinking helps prevent flooding emotions. And information helps against loss of control. Do something helps against helplessness. And if you do this, you have to care for yourself also. You have to know, I can go into this talk and I will feel, even if it is very difficult, I know where is my center and I can do it. And this means, and here we go to a switch to positive psychology, from where we also take a lot for this situation. It is a very new concept, and it is also to look at the positive moments, to look at this where you can support the family, look at this where you can support the patient, and do it not only in the hospital, do it also at home. Every day you should have a positive moment, a positive experience. Look that you have consciously contact with the family and also in your privacy life when you go out from the hospital. You need social contacts, everyone. And then focus on your strengths. Everyone has strengths which he can bring inside this situation. And be aware of the sense and the benefit to say thank you to the chance of supporting a family and persons in a very difficult situation. And you can contribute to support the gift of life. Thank you.
Thank you, Annalise. Any questions about this topic?
Wojtek, you don't ask something?
Yes, Dr. Shaheen.
Okay.
Thank you very much.
I would like to talk 1 week about this. No, I'm sorry if I'm delayed.
Sometimes the coordinator had a problem with the family, the reaction of the family.
Yeah.
And how they answer, the immediate answer. What do you think the coordinator can do in that situation order to calm him down? And either he can stop talking about subject, or he continue, or he did something else.
Yeah, you have to make a difference. You have the normal grieving reactions. Like it can be a little bit aggressive, it can be depressive, it can be everything. Yeah, it is not true. You made a thought like this, so you just react to this grieving reactions. If somebody wants to throw back, let him do it. Let him express his anger. He needs it at the moment. It is not your duty to calm him down. Let him, and let the people the time to find out that it is true, that it is not changeable. Let them do, but also you. It's the time he needs. Yeah, it is different. Some people need half an hour. You can say, okay, I leave you now, and if you need something, please come, and I will come after 10 minutes to look after you. But let the people do their reactions. Let they say everything, and you just have to normalize the situation. It is normal that you feel like that, or that you feel anger like that. Many people in this situation react like that.
Okay. But can I continue, please, Mr. Chairman? Can I? Sorry, Anna. Again, what can I understand from you that once he is in anger, so I will leave him. I will not sympathize with him, or I will not hug him to tell him, no, please calm down.
No, you just stay, and if he will tell you what to do, he will say, please let me alone now, I cannot. So you say, okay, I'll come back later on.
This is what I want.
I have a question. It may be not directly related, but you talked about how to approach a particular family. My thinking is how to build the culture of donation in the society, how to build on success stories, so that we go through coordinated media approach, because one negative coverage just puts us way behind. So what's your views on how do we approach the bigger family, the society, in a coordinated manner?
Do you have this like videos from donors and like honor tables or something like that, and you have to make a program? What can we do with the media? How can we report successful transplantations? How can we put the topic in the schools? How can we bring good news from like wie heißt das, die Sportdinge da, die es gibt für die Transplantierten? Transplanted Olympics, like this. You can make several events or things to do that. But I think even more important is to work with the hospital staff, because they go outside and they have their families. Sorry, thank you. They have their families, they go outside and they will tell everybody at home, I am proud to work in transplantation, and not, I don't say I'm working in transplantation because I don't know what the people think about.
Any more questions? Okay.
Yep.
Yes.
Last question.
Excuse me, I have a question here. Regarding the time between the breaking the bad news, when you inform the patient he have his relative is die, how long you think we have to give the patient? In Saudi here, usually we give from 4 to 8 hours. We have a TBM before in course, and they told us they prefer to talking to the family in the same time. What do you think?
I think with some families it will be possible at the same time, but it is not. There are many studies also, they say it is not good to make it at the same time. So let a little time in between. But if it is half an hour only, or if it is 8 hours, it depends how you get the contact with the family.
As your methodology in the approach, how you approach the family and how you know about them? Before, I think very important to put your strategy before approach the family. You take this strategy from the doctor in ICU, nursing, all the people who is around the brain death case. Because he is not know this man who approach him in that moment, but he makes his strategy, and maybe he will be know when he speaking with the family, he know what going on with this family. Some families need half an hour, some families need 6 or 8 hours. I think that the coordinator, he must be know that in the same time, and he give a chance or not.
Yes, and if he comes for the first time, he does not have the relationship to. So it's a process they should start together first, and then when he knows the family, it's possible to get in contact and possible to get the decision process.
So it depends the situation of the family?
Yes.
At the same time. Thank you.
It was the last question, but I am outside after, and we can. Yeah.
Sure. Yes.
Yes, we have because we have three parts. What do you call it? Missing of yours. You got it or not?
Anybody has bad in his? Maybe he forgot it in his bag or something. No.
We'll find it.
Talking about the voting pads. No. Somebody has. Okay, I mean, because I told them to keep it till the end. So.
Okay, we'll have now the scenarios.
Excuse me. We are going to have almost 2 hours from now till 5 o'clock. We'll close at 5. We'll have quick scenarios, and it is fun. You will vote. Somebody will comment on the answers. Okay, and we move fast to cover as many as we can, both the medical side and also family interviews, and hoping that to have like 10 minutes also of coffee break in between. So we'll start, if you allow me, with the first scenario, and we'll proceed after that to the rest. And you'll see, you'll get the hang of it. Okay, the first one, I read the scenario quickly, put the options, and then you will vote. Full clinical brain death diagnosis was positive. The electrolytes are normal. Temperature was 32 degrees centigrade. The diagnosis was made once by a competent and experienced neurosurgeon. You were asked to approach the family for consent. All the following are true except diagnosis is not valid yet because hypothermia can mimic brain death. B, the diagnosis should be completed by 2 examiners to be valid. 3, the diagnosis is correct because electrolytes are normal. D, a clinical exam is not enough to confirm brain death, and other tests such as EEG should be performed. You'll enter the answer, according, you don't have letters, so you enter 1, 2, 3, 4. Okay? Can they start voting? Okay, let's start voting. Okay, we have for number one, 57%, and the others have lower percentage. Okay, and
no. The question.
All, I mean, maybe you did not catch it. All are true, except. So maybe somebody did it wrongly. Since this is our first case, we'll pass on it. I think Dr. Abdul Qayoum is going to tell us why the third choice, the diagnosis is correct, because electrolytes are normal is wrong, and the rest are true. Dr. Abdul Qayoum.
Yes, okay. Now the reason for putting this scenario that you just wanted to stress upon temperature. And the new protocol that the temperature last is going to be not less than 34. 34. In the past it was 35, and now our brain death committee, they met and they put it on that diagnosis will not be compatible with brain death unless or until the patient is cooled down by blanket or by the. Can I have the question again back? The same question, the question back, so that they can read out. Okay, so the temperature should be 35, and concerning the neurosurgeons, it's not necessary neurosurgeons to be.
What about the one surgeon?
The neurosurgeons is not only surgeons, neurosurgeons, neurophysicians, anesthesiologists, ICU doctors could diagnose the cases. And electrolytes the correct answer is C. That diagnosis is correct because of the correct answer is C because it is except.
No, wrong. You mean the wrong answer.
I mean the wrong answer.
Yes. Okay. Now move to the second scenario. Second scenario. Okay, a brain death diagnosis. Okay, should not be performed if the death cause may be related to medical negligence. Number two, the potential donor is undergoing severe hemodynamic disturbances. Third answer is severe anoxia, cardiac arrest, and prolonged hypotension occurred before. Four, the patient is under continuous barbiturate infusion. Infusion, not perfusion. Okay, you can vote now.
They voted it.
Okay, the fourth answer got the highest percentage of 61%.
And that is the correct one.
And this is the correct answer. Dr. Abdul Qayoum has a little comment on each.
Well, we had been talking in Dr. Robert's lecture about maintenance, and Dr. Qayoum about diagnosis, about barbiturate infusion. It was given him perfusion. It is infusion. But if the patient is under barbiturates and the therapeutic level is high, you have to check the therapeutic level. The diagnosis should not meet. You should not do the diagnosis in such cases. Either you wait for 5 days to that this level will be out of the blood, or you check the blood to check the therapeutic level, and then you diagnose the case. That is the most important point. Is no medical negligence and hemodynamic could be corrected, and severe anoxia could be corrected, and the rest will be corrected by the ICU doctors. Yes, Dr. Antoni?
You're talking about clinical brain death diagnosis.
Clinical brain death diagnosis.
What if you do an angiography or a scintigraphy and you have no circulation to the brain?
So let's compare brain death.
Can you confirm?
Yes, certainly, yes. Yes, we do. Well, we don't do carotid angiography in all cases here. In Saudi Arabia, you know, it is EEG. Even it's not available in most of the cases. In the future, we may go for the clinical only. But it does confirm, as you said. Yeah, I got your point.
Yes.
The point.
Yeah.
You need to say if you do the angio with barbiturates and you found blood supply, there is no perfusion. It's diagnosed.
Yeah.
Especially if they're on RTA or something like that.
Okay. We'll move to the third scenario. Which of the following are false regarding marginal donors? It is contraindicated to use. Number 2 is reserved only for pediatric recipients. 3 is considered equal as standard donor. Number 4, all the above. And number 5, none of the above. You can vote now. The highest answer is number 4, but still lower percentage than expected, 42%, and the none of the above. I don't know why people. Dr. Abdul Qayoum is going to comment on this.
Okay, the marginal kidneys are not contraindicated. Could be used for certain donors. In Scott, we call the ASU, the transplant center, and we give them the data, and they will decide whether to receive it, and usually they do. And then, of course, the ideal criteria for the donor, we are talking here about kidney, by the way, because there is no marginal for the liver or there is no margin for the heart. So we're talking about the kidneys. So ideal is 10 to 30, 39 years old and normal creatinine and there is no CVA. We take, if there's CVA and the age above 60, we consider it marginal. So the answer in the first question, if you go back, is all of the above. That's from 4 upwards. So you could use the small kidney, marginal kidney for certain patients.
Okay, scenario number 4. Yes.
Can we use for pediatric marginal kidneys? Usually not. Usually don't.
And sir?
Huh? As you said, not.
Should be 5.
You had a case in your hospital, 70 years old, and you had been looking for a marginal kidney, haven't you?
Excuse me.
No, we don't give. We give pediatric to pediatric, and good kidney we give it to pediatric.
You see, when we said in the question was, I believe it was clear. Which of the following are false regarding marginal donor? So all of the above are false. So we still have, the same answer as 42%. Maybe some people missed the false. When they, okay. We'll have better chance in the next scenarios. Number 4, the quality of disease donor could be affected by age, CVA, cardiovascular disease, infectious disease and hepatitis, renal failure, all the above, none of the above. And you can vote now. The highest percentage, 52%, is to none of the above. And the answer number 4, which is correct, is 30%. Still don't have, maybe the question was misunderstood, but I thought it was clear. Dr. Kamal, our coordinator at Scott, maybe can comment on this scenario.
Press on the mic. Press on.
Regarding this question, of course, the age is a limiting factor. Is not a limiting factor for organ donation. All of the above affecting the quality of donor, and this question is put to identify the extended criteria donor, and to give an idea about how we can choose or select the donor, how we evaluate the donor. So, in addition to age and renal failure, there is also other factors that included in evaluation of the quality of donor, like hypertension, diabetes, any history of heart disease, any infectious disease, any malignancy. All of this affects the quality of this donor.
So
the
the key word here is quality. The quality of the diseased donor. Next scenario, an ICU nurse calls you and tells you that there is potential donor in her unit. She gives the following details. The donor is 23-year-old and deeply unconscious after a road traffic accident. He is on a ventilator and requires continuous sedation as he otherwise fights the ventilator. What is the best answer? Your best answer is the patient is brain dead because he is on ventilator and comatose. The patient is not possibly brain dead yet because he is fighting the ventilator. We should give the patient more sedation and then proceed with the diagnosis of brain death, or I agree and request to do the apnea test. Vote. They are voting. Okay. Number two, which is the correct answer by most of the audience, and Dr. Kamal also is going to comment quickly on this scenario. Dr. Kamal.
This question is clear regarding the ventilator, as the patient is fighting the ventilator, so he is not brain dead. So this is the right answer. He is not brain dead because he is fighting the ventilator. And regarding sedation, sedation may cause brain depression. So we should wait until the sedation effect and the level of sedative being down until we diagnose the brain death. This is to remind us with the exclusion criteria for brain death diagnosis that was told by Dr. Al-Qawi in his lecture.
Yeah, so we don't give sedation, then diagnose, okay? But maybe you have to give sedation for somebody who is fighting the ventilator after all. Move to the scenario, number 6. You call the transplant center and speak to the local coordinator. We have a kidney from a 55-year-old donor who has past medical history of diabetes mellitus. He interrupts. Sorry, we cannot accept it. What is the best answer? Number 1, he is right. Diabetes is an absolute contraindication for organ donation. He is wrong. Number 2, kidneys can be donated after further evaluation. 3, he is right because the age of the donor is above 50 years old. D, he is wrong. Kidneys can be used only for pediatric recipients. You can vote. Number 2 got the highest percentage and it's correct. Dr. Kamal is going to comment quickly on this scenario.
Diabetes mellitus is not an absolute contraindication for donation. It's just a relative contraindication. The kidney should be evaluated more for donation. The age is not a limiting factor for donation. The age above 50 is not a limiting factor. We can take marginal kidney, as Dr. Fitzgerald said, that age is not a limiting factor for donation. And the last option, that the kidney can be used only for pediatrics, this is untrue, this is wrong, because this kidney is a marginal kidney and shouldn't be used for pediatric. It should be used for adults.
Number 7, an organ donation coordinator didn't have good results in obtaining donors, although he works in a hospital with an active and busy ICU and neurosurgical units. His hospital director asked him to improve the situation. The coordinator writes to the ICU personnel, introducing himself to them and asking them to inform him whenever consent has been obtained from a family of a dead donor. All the following are true except, all are true except. He should have been available personally to ICU, not to write a letter. Number two, if he has to introduce himself, this means that he didn't do his job properly before. Number three, it is his job to follow and pick up possible donors from the start and not to wait to be informed after consent is obtained. Number four, his current approach is the proper way to improve the situation. You can vote. Number four got the highest percentage and is true. Dr. Zaid can...
Yes, for this scenario, I think the wrong is 4 because this enter for the jobs of coordinator. I think the coordinator must know from beginning by the cases, by the branded cases, and he will come for other scenario, for jobs. He must know from early until we retrieve the case. So 4 is wrong.
No,
wrong.
He shouldn't be doing this anymore.
Yeah.
Number 8, a remote ICU has a possible disease donor. They tell you, look, we don't have anybody here who can diagnose brain death or maintain organs. All are true except, first, arranged for a quick transfer of the donor to an expert ICU. 2, arrange for experienced team to come for diagnosis and management. C, or 3, prepare for adequate training for diagnosing and maintaining organ donor of the ICU staff. 4, proceed immediately to convince the family for consent. You can vote. Yeah, the audience are still right. 64% voted for number 4, which is true, and I think Dr. Zaid can comment.
This scenario, we face many cases at this scenario, and sometimes we go to the hospital. There is a potential brain death. We cannot diagnose the case because no consultant there. Sometimes no EEG machine there, no technician. So I think we can shift him for other hospital, qualified hospital, to diagnose the case, or we can send a consultant neurologist or any consultant there to diagnose the case. And we can provide them by EEG or anything to diagnose the case.
Also we arrange for their training.
For training, also symposium.
Yes. Okay. Number 9, the ICU doctor is known to be uncooperative. He, for some reason, is not helping with the organ procurement program. You have already spoken to him with not much result. What will you do? All are true except. All are true except. First, you need to probe into underlying causes for his attitude and try to solve it. Number 2, his administration should be informed to take disciplinary action. 3, consider to offer him incentives for extra time he spends with the donors. 4, appoint him as a regional program director. You can vote. The participants are also true here, correct here in answering the question. 69% voted for number 4, and they are right. Dr. Zaid also
I think we cannot point him as director in this because he's, I think, an obstacle for the program. So, we face also, as this doctors or other staff, sometimes they are against the program. Usually we invite him to attend our lectures or symposium. We try to approach him. We try to let him know what is the brain death, what is the idea of organ donation in the kingdom, and I think we succeed in some cases as this.
Number 10, which is the most efficient way to detect a possible brain dead donor? A, send monthly letters to all ICUs inquiring about the potential brain dead pool of patients. Number 2, identify patients hospitalized due to the neurosurgical disorders or neurological disorders. Number 3, wait for a brain death notice provided by the staff of the different hospital units. D, pay daily visits to medical and surgical ICUs that can generate potential donors. You can vote. Also, the participants are correct again. 77% elected the right answer. Dr. Zaid, quickly.
I think this is the main job. The main job of the coordinator to do daily visit or every day, 2 days or 3 days visit for ICUs to report the cases early. Because the time very important from report the case until we get consent to diagnose the cases and to solve the obstacles which we face in ICUs. So visit ICUs, create personal relation with the medical staff and with the admin staff there in the hospital to inshallah go with the program for successful.
Number 11, a 45-year-old lady was diagnosed as brain dead. The past medical history revealed that she had carcinoma of the breast from which she was totally cured for the previous 12 months. Her relatives are very keen to donate her organs. What is the most appropriate answer? Number 1, relatives' opinion should be respected and we should accept this case for donation. Number 2, cured carcinoma can be accepted regardless of period after cure. Number 3, breast cancer is considered as an absolute contraindication for organ donation. Number 4, we should wait 3 to 5 years for cure of the breast cancer to consider donation of organs. You can vote. The percentages are distributed between 2, 3, and 4, but 4 is the correct answer here. Maybe it was not clear to some that wait here this allow 3 to 5 years of cure of breast cancer, but it's not complete contraindication. Dr. Zaid?
I think it's the 4th. I think this kind of tumor, breast carcinoma, it needs 3 to 5 years. Should be cured 3 to 5 years to take this donor, can take this donor. I think there is absolute contraindication for organ donation, as malignancy is one of them, but there is some kind of tumors can take it as some primary brain tumors and cytocarcinoma of uterus and breast after 3 to 5 years, of course.
Of complete cure.
Of complete cure, yeah. Yeah.
Okay. Number 12. A 20-year-old patient was admitted with high fever and neck stiffness. A lumbar puncture showed high polymorphic white cell count. 2 days later, he had a cardiac arrest and transferred to ICU, where brain death was diagnosed. You were called to consider him as an organ donor. What is the best answer? A, or 1, this is mostly bacterial meningitis and needs to be covered with antibiotic at least 48 hours before retrieval. 2, his condition is an absolute contraindication because of sepsis. 3, he is not a suitable donor because of cardiac arrest. 4, lumbar puncture with high polymorphic white cell count is compatible with viral encephalitis, which is a contraindication for organ donation. You can vote. Yeah, number 1 is the right answer, 49% for it. Number 4, 36%. Dr. Zaid is going to comment on this.
Yeah, the true is 1, because the bacterial meningitis not contraindication. We can cover by antibiotics and for 24 hours and or 48 hours and take it. Viral meningitis, if the viral is active viral meningitis, is an absolute contraindication. But bacteria, this bacterial, we can cover him by antibiotics and take.
Yeah, because of the high polymorphic nuclear count. Okay, number 13. A potential donor shows the following results. Echocardiogram shows 2 hypokinetic areas with reduced left ventricular function. His renal functions and liver functions were normal. He is hepatitis C virus positive. He has a history of severe chronic bronchitis, but was free of any infection. Will you consider him for donation? 1, no. He is not fit for donation because of hepatitis C virus positivity. 2, consider the lung donation, but not the heart donation. C, can be considered for kidney and liver for specific recipients. Number 4, can be considered to donate all organs. You can vote. Okay, number 1, 36%. Number 3, 45%. And we believe that number 3, is the right answer. Okay, Dr. Sayed is here.
No, it's okay. Well, you are talking about hepatitis C, and the C could be given to a recipient C. So there is no problems. C to C. This is for the kidneys. Concerning the liver, some centers they do, if they badly need, and there is emergency, they take hepatitis C for their patient who is dying to be transplanted, and it happens in King Faisal. But the hepatitis C could be given only to a hepatitis C positive.
Yes. Here, we can consider the kidney and liver for specific recipients. We cannot consider the lung because of the chronic bronchitis, and we cannot consider the heart because of the ischemic changes noticed on the tests. Number 14, a potential organ donor was noticed to be passing 4 liters per hour. His plasma sodium was 160 millimole per liter. His urea is rising and his blood pressure started to drop. What is the most appropriate answer? 1, the potential donor has diabetes insipidus and needs fluid replacement and vasopressin. 2, the donor is in shock. Dopamine and norepinephrine should be the initial step of management. 3, the potential donor has hypernatremia and should be treated with D5 water only. Number 4, dialysis is the treatment of choice in this donor. You can vote. Okay, number one is 62%, and this is the correct answer. You have to give vasopressin, as we heard this morning, for diabetes insipidus, and fluid alone is not enough, and may lead to hyperglycemia because of diuretic effect, and dialysis certainly is not the treatment of choice in this donor. We should not start with depressors as the initial step, but following replacement of fluids or correction of the volume status. Number 15, a potential multi-organ donor was found to be positive for hepatitis B virus. What is the best answer? A, or 1, hepatitis B virus positivity is an absolute contraindication for organ donation. Number 2, other serological tests and liver biopsy are needed for final decision about organ donation. Number 3, only tissue donation is accepted in this situation, meaning cornea and bone. 3, the liver can be accepted for patients with history of hepatitis A virus positivity. What is the best answer? You can vote. Okay, here we have wide distribution of answers. 27% for the first one, hepatitis B virus is an absolute contraindication for organ donation. We believe that organs can be given to recipients with hepatitis B virus positivity. The second one, other serological tests and liver biopsy are needed for final decision about organ donation, and we think that 33%, which is the highest percentage here, we're right. Number 3, only tissue donation is accepted in this situation. No, we can use the kidneys at least, if not other organs, depending on their condition. D, the liver can be accepted for patients with history of hepatitis A virus, which is not mentioned here. Hepatitis A virus does not leave carrier state in most of people, and we're talking about hepatitis B. Number 16, a 52-year-old man with advanced hepatic cirrhosis from alcoholism. He was admitted for treatment of ascites, and cerebral hemorrhage is detected, which caused a brain death. The serum creatinine level is 2 milligram per deciliter. Sodium in the blood is 120 millimole per liter. Potassium 3 millimole per liter. Sodium in urine is 5 millimole per liter. Potassium in the urine is at 20 millimole per liter. Proteinuria is negative, and the abdominal sonography shows normal-sized kidneys. The coordinator rejects the donor. What is the best answer? Kidneys can be used from this donor. Number 2, kidneys cannot be used due to high serum creatinine. Number 3, liver cirrhosis and alcoholism are considered absolute contraindications for multi-organ donation. Number 4, only corneas can be accepted for donation. And you can vote now. Okay, number 1 is the correct answer by 56% of the participants. The kidneys can be used from this donor who has hepatorenal syndrome. We know that the liver is the problem. The kidneys are innocent bystander and can be used because the tissue is, or parenchyma of the kidney is still intact. And high serum creatinine cannot be used against the donor for donation, because it will improve the function once it is transplanted to the recipient. Also, liver cirrhosis is not, and alcoholism are not absolute contraindications for multi-organ donation. We can use most of the organs if they except the liver, and certainly corneas are not the only tissues accepted for donation. Number 17, the doctor tells you you cannot use this donor because he is CMV positive. What is the best answer? Number 1, positive CMV is an absolute contraindication for organ donation. Number 2, CMV positive donor can be used after specific management to recipient. Number 3, all organs except liver can be donated. Number 4, only corneas can be used. You can vote now. The participants were right, 54%, the highest percentage for the correct answer. And we have Dr. Abdullah Balkhair, coordinator working with us, he can comment on this, please.
In this case of cytomegalovirus infection, I think that we have to look for the details of the serology. If the infection is acute, we will refuse this case. But if the infection is chronic, we can accept this case, but not for any recipient. The recipient also should be positive for CMV, and of course we will cover him by antiviral medication. So we can use all the organs. Cornea,
you mean immunoglobulin and
yes.
Antivirus?
Yes.
Oh, okay. And here it says all organs except liver can be donated.
No, even the liver.
Even liver.
Yeah, after more evaluation, because the CMV can affect the liver, but if the liver function is good, we can accept it.
So proper treatment of the recipient and protection can help, the donation. 54% voted yes. Yes. Number 18, after properly being diagnosed with a brain death and consent was obtained for multi-organ donation, the donor's blood pressure began to drop despite adequate fluid and inotropic support. All the following are true except we should reject the donor because of a drop of blood pressure despite adequate fluid and inotropes. Number 2, consider urgent harvesting of organ. Number 3, prepare for non-heart beating donation. Number 4, tissue donation is accepted in this situation. We said all true except. All true except. You can vote now. Again, the participants were right. 60% voted for the right answers. Dr. Abdullah Balkhair can comment on the answers quickly.
In such cases, if the ICU doctor is trying to do his best with the donor, but BB is still going down, we have to consider urgent harvesting of organs before cardiac arrest. And in order to increase the number of organs available for transplantation, we can also, if there is sustained and irreversible cardiac arrest, we can ventilate the donor while the arrest procedure being carried out, and also we can insert a special catheter to isolate the kidney circulation. This catheter has 2 balloons to be inserted through the femoral artery, and the balloons are inflated in aorta just above and below the renal arteries. A cold preservation fluid is then continuously infused until harvesting occurs.
Good. Number 19, you have been informed that a patient with a well-functioning kidney transplant is in an ICU and has been diagnosed as a brain-dead donor. You have been asked to approach his family. The most appropriate answer is the transplanted kidney cannot be utilized because it is transplanted graft. Number 2, the transplanted kidney, in addition to other organs, could be utilized on condition that there is no other contraindication for organ donation. The third option, no need to get consent from family since the consent was obtained from the first donor. You can vote. Number 2 got the highest percentage, 58%, which is the correct answer. You know, we still can use the transplanted kidney, and we can use other organs also from the donor, and we still need the consent each time we get a new donor to donate organs. Number 20, the report that came with a harvested kidney had the following facts stated. Donor, 25 years old. Cause of death, head injury due to fall from height. Left kidney, it is a left kidney. 2 renal arteries on a patch. 1 renal vein. Last hour urine output 1.5 liters. The renal transplant surgeon was furious and asked you to call to get some missing information. You would ask for all of the following except you will ask for serum creatinine, cold ischemic time, microscopic description of the kidney, pulmonary and expiratory pressure, the PEEP level on ventilator, the septic screen, and viral serology. You can vote. We have good group here. You know, number 4, 46% voted that they don't need the PEEP level on ventilator. You know, for the other options which we consider essential, serum creatinine is important. You know, if you are dealing with a kidney, cold ischemia time, so you can know if you are going to face problems after transplantation. The microscopic description of the kidney to rule out any problems like tears or any masses growing on it. And septic screen and viral serology are routine screening tests, you know, for evaluation of any donor. Number 21, regarding multi-organ harvesting, all are true except the abdominal and thoracic surgeons start the intervention. The organs are inspected for pathology. The organs are inspected for pathology. Number 3, cannulation is done by the renal surgeons. Number 4, wide exposure is needed. Number 5, the type of surgery depends on which organs are going to be harvested and the stability of the donor. All are true except. You can vote. Number 3 got the highest percentage, 42%, and it is the true one. I mean, that we do all the others except to this one. Dr. Iyad with us from Scott is going to comment on this case.
In multi-organ procurement procedures, usually the liver surgeon, liver team will cannulate the aorta. And after that, the ligation, it's done by the heart and the liver team together after the cannulation.
The next scenario, which of the following is the correct order of multi-organ retrieval? You do heart, then lung, liver, pancreas, kidneys, tissues as cornea and bones. Number 2, pancreas, corneas, tissues, then heart, lungs, liver, and kidneys. Number 3, kidneys, liver, heart, lungs, pancreas, and corneas and bones. You can vote. Here there is a split of voting. Number 3 got 43%, number 1 37%, while the least percentage was number 2. Dr. Iyad can tell us about the right sequence of multi-organ retrieval. How do you do it in the operating room?
The first is the appropriate decision. The lung and the heart is removed first. After that, lung team, liver team removed the liver, hepatectomy, and at least pancreas, and after that the kidney. The first scenario.
The next question. The maximum time for organ preservation are the following except heart, lungs 3 to 5 hours, liver 12 to 20 hours, pancreas 8 to 12 hours, kidneys 24 to 72 hours, corneas 7 to 10 days, bone 5 days. All the following except, and you can vote now. It's not here. Okay. Also, there's wide distribution here of voting. Number 6 got 38%, the highest, which is true. We are going to ask Dr. Iyad, also an expert in surgery, because he does the retrieval and helping in the harvesting teams of the different hospitals, and he belongs to Scott. Dr. Iyad.
All are correct except for bone marrow up to 3 years, and the preservation time, and for bone and skin until 5 years. Not 5 days, 5 years. 5 years.
We are going to take 10 minutes break, during which you can have the Asr prayer, and then we meet for the last session. It's about family interviews, and Ms. Annalise Fitzgerald is going to moderate the session. We have scenarios. We'll use the same format, and we ask the comments of Scott staff. Thank you. Good afternoon, everybody. You know, this is the last session. We'll take from half an hour to 45 minutes before you leave. We'll use voting as we did in the previous session, and we ask everybody to participate. All people have pads, voting pads with them now? Okay, so we can use, you know. I appreciate, you know, the responses of the participants. They were great. They mean, you know, that they know many of the stuff about organ donation and care of patients. Now it comes to a more difficult part, is how to convince families to consent. We have some scenarios. Ms. Annalise Fitzgerald is going to moderate the scenarios. She's going to read them. You vote. Then we ask somebody from the staff of Scott, you know, to comment on the answers. Okay, Ms. Fitzgerald can start.
Okay, thank you. And we will try not to get a confusion with the voting system. So the first question. Are you okay? We can start?
Yes.
Yep. You meet the father of the brain-dead child. He is very distraught. He says, I have no objection to donation, but the child's grandfather, who is at home, refuses. What is your next step? A, immediately next to kin, so the father is the only one to make decision of donation without the need of grandfather's opinion. B, respect the opinion of the grandfather and arrange for meeting with him. C, stop all the efforts to get consent. I'm sorry. Stop all the efforts to get consent. Because you can not convince the grandfather. And D, we can contact the grandfather by telephone and get consent. So,
with the number of years, you ask them to vote.
Now you can vote, and when the number is 0, you have finished your vote.
Yes.
So, number 2, 91%. So this is extraordinarily good, no? I think Hassan could say something to this. Hassan.
Yes. Now it's good because everyone, I think it shows the correct answer. You know, the culture of Saudi people, it's different sometimes if we compare the other country. Because sometimes the decision, it's not only for the father or first kin. Sometimes they need to choose the other to give him. One example, if the father refuses, sometimes they say for refusal, they give for the grandfather because he don't like to donate. But sometimes it's the father agree, but must be take the permission from the grandfather. In that one, it's better to make appointment with the grandfather, then we go to him, we meet him, we explain about organ donation. But before we explain about organ donation, must be we know if the father, he knows about the condition, about the patient in ICU. Because we cannot go and meet him and talk about organ donation until we know the grandfather, he knows he's totally deaf, then we talk with him.
Very important. Mm-hmm. So second question. You ask the son to consider consenting his father's organs. He says, how can you say that he is dead? Look, I can see his heart beats on the monitor. All the following are true except. So except. Explain to him the diagnosis of death by brain function criteria. B. Explain to him that heart beating will stop once the ventilator is shut down. C. Heart can be replaced, but brains cannot, so hearts are not noble organ anymore. D. No need for medical details, since diagnosis of death by brain function criteria is part of regulations approved by the government. So please vote. And stop. Yeah, we have here 45% for the answer 1. It was explained to him the diagnosis of death by brain function criteria. Yeah. The 4. Maybe this was not, I did not good explain, it was except 1.
All are true.
All are true and 1 is not true. So, all are true, and Mr. Salfi, he will explain why 1 is not true.
Well, thank you. Well, I'm surprised from this result, but I think maybe somebody not understand this
the voting
question
system.
very well.
My English.
Actually, yeah.
Actually, only 11 persons responded.
It's confusing. Really.
Only.
And also, 4 is. Well.
Confusing.
I didn't think so. It's a good idea to repeat it again, but we have to answer about it. Of course, the correct one is the last one, because in that time, the father or I think the father in bad situation, and even many people explain to him, the doctors and ICU staff, about the situation. He cannot believe it, or he don't like to accept what they say. So he like the people to repeat and repeat and repeat. Every time, maybe every time you have a chance, he will understand what you say, and maybe you will get, inshallah, the consent. So I think all this answer is right, actually, except the last one, because we cannot say it's for the government. That time he will be angry and he will jump and he will be in trouble. So you have to be nice with them and explain, and to be patient to have the consent. Thank you.
Yeah, thank you. And it's always also a part of the grieving process, not to say it's not true. Third?
Number 3. Case number 3. Go ahead.
Case number 3. The brain death has been diagnosed. The ICU nurses told you that the potential donor's next of kin lives in a remote village and they could not contact him so far. What should we do now? A. To try our best to locate the family, since we cannot proceed with consent without them. B. Find out relatives living nearby to get consent without need of immediate next of kin. C. No need for consent, since we may lose the donor while waiting. And D. Local governor can sign the consent on behalf of the family to save time. So please vote now. And take your time, 1 second, finish. This is very good, no? It is A, and Abdullah will explain why.
First, we agree with the number 1. Our kind of this job depend on trying because it is the end of this mission. The end of this mission is the goal of all the activity for the team. So The trying one time, 2 times, sometimes we are giving the family time. Sometimes we are not considering their first decision because it is relating to emotions or something like this. So sometimes we are giving the family maybe hours, sometimes day or 2 days, and approaching them again, trying to take the last opinion for the donation. The decision maker is the close relative. Here in our society, we have the close relative. Number one is the father, or the brother, or the very close relative from the family. So nobody can decide from the government or from the neighbors or from the family unless taking the official decision from the one who can decide to take the organs, to give the organs, or not. So we are trying to find this decision maker to take this last decision from him for donation.
Mm-hmm. Thank you.
Thank you very much.
Next. The next of kin is willing, but he says, I will only allow you to take 1 kidney only. What will your approach? What will be your approach? First, or A, explain the multi-organ donation will help more patients waiting for organs and will not make any difference for the body. B, there will be no disfigurement to the body because we have trained surgeons for retrieval with utmost respect for the body during harvesting. And C, we accept the offer requested by the next of kin without any attempt for multi-organ donation, so he will not decline. And D, accept the consent and retrieve other organs without telling the next of kin. So what will be your approach? Please vote. Very good. Are you content? Yeah. So, Hassan, would you?
I think, yes, the correct answer is take the 80%. But usually, when we speak with the family, usually we talk about organ donation and we explain to him there is one opening. If he donate 1 kidney or donate liver, pancreas, kidney, heart, it's the same opening. And we are close the same. We don't give him the choose to choose which organ, because when I speak with them, I speak about organ donation. I am not explain. Sometimes if the family ask me, I am not give him only about kidney or something. Usually we talk about organ donation as general.
How often in the praxis you have this situation that somebody asks you just to take the eyes or just to take this?
Yeah, and especially when we talk about sometimes the cornea, we are facing everywhere because when we talk about the interior, inside organs, nobody can see, but usually in everywhere, the family or the relative, they want to see the death, the body. And that one, we explain to him, we are not harvest the complete eye, we are only retrieve the cornea. It's something nobody can. Still, there is high percent from the refusal because the family, they don't like to touch the eye. Because they say the eye, everyone they can see, we don't like to make trouble with the other member from the family, and they are refused. But most from the people, they are now understand and accept, donate the cornea.
Yeah, and especially the eyes.
Especially the eye.
Yeah. Thank you.
I think we have one case, this is for joking. When we faced with one donor here, he think we are calling about 1 kidney. He is in the ICU and he's a brain dead, clarified, and he just only offer 1 kidney for us. And after finishing the harvesting, he need from our side to return back the body to the ICU to complete treatment after retrieval. He thinks that he's still alive, and he only just like a living donor, he can give only one kidney.
Something wrong in the process.
Yes, this is, the message is not clear for
Yes,
it.
yeah. I think if people ask for just to take one organ, just to take one thing, maybe you have to make clear that it does not make a difference. The person is dead. And very often if they ask for one kidney, like you said,
I want to add something. Usually when we talk with the family, we are not put any condition from us or from the family. Organ donation, it's mean donation, it's mean donation. But if sometimes they put condition, it's mean they are hesitate. And they need more explain, because if I explain everything in clear, they are give clear consent.
Yep. And it's clear information, but it is also information given in a very soft way, you know. It is, you have to choose the words, not to use harvesting. It is no need to use words like this. Yeah. Thank you very much. Next. We are in a hurry. It's 5? Yeah. I am happy to allow you to take my son's organs. The father says, but he adds, on condition you tell me who the recipients are. What is the best approach to handle the situation? A. We tell the father the recipient's name, since there is no harm to spread the information. B. Giving names of recipients is forbidden, preventing possible blackmail. C. We promise to give names of recipient later once cross-matching is completed. D. Names of recipients will be published in the newspaper. Start now, please. Too late. So, it's number 2. Giving names of recipients is forbidden, preventing possible blackmail. Yeah? And it is like this, Saleh, you know?
Well, I can agree with you. Legally, actually, it's like this. But in my opinion, we have some situation. I think we have it with Dr. Riyadh before a few days ago. And this guy is, we are sure 500% he's not abusing this thing. So I didn't think so. It's making sense if we, not complete information, just we told him the people who's receiving is some child or something like that. We have like this information. Of course, we will not give him any information if we know and we are sure he's abusing this. But in our program, we never ever giving such like this information. Just we told him about who's receiving this, just from good communication with the other, or just building the trust between us and the other family.
Yeah, but we don't give specific names.
Yeah, of course.
Never.
Of course. Yeah, because we're afraid actually from the abusing for this thing. So we carefully in this.
And very often recipients also ask, from whom did I get the kidney? Was it a man? Was it a woman? Was it a child?
Yeah, exactly. Just we give him maybe the sex or the age or something like that, just to have a communication actually, and for just to kind of media even from the recipient people or from the donor actually, because they feel they are what we call, this is the social thing in our program actually.
Yeah. Thank you. Number 6, and number 6 is the last one. You go to see the father who has been told of the death of his son. He is clearly in shock. What will you do? A, you wait 4 to 8 hours for the shock to subside, then arrange for a meeting. B, no need to wait to obtain a consent because you may lose the donor while awaiting. C, bypass the father and get consent from other family members. D, stop all efforts to get consent because the father will not recover from his shock in the near future. So what will you do? Please vote now. First, 82%. Should be right, no? Abdullah, would you say something to this?
It should be more than 82.
Yeah.
So, this kind of job depends on the shock. This is the main point in our job, the shock. Because in this situation, he is receiving very bad news. So, in B and C and D, they said no need to wait. This is not right, because our job is depending on to try and try and try to find good time to talk with the family. Pass by the father, also this is not a try, because he is the decision maker. We cannot pass by him. Stop all the efforts, because the shock is the main point in our job. So we cannot stop. We should try again and again. So that's why most of our colleagues here they chose number 1, because we are working with the time. We are working and fighting the time to get the consent from the relatives. So actually we are giving for hours, 8 hours, sometimes 1 day and 2 days. It is depend on the situation of the decision maker. Yeah. So we are giving time to choose the good time to talk. Thank you.
And even now with all the technical possibility, it is possible to give more time if it is necessary.
Yes, this is right.
But sometimes the shock is, the shock is help you
yeah.
to get a consent.
Yeah.
Because we have it several times actually.
Would you take your microphone?
Sorry for that. And several times I think we have a case actually, he's shocked and he's crying, he fall down, we're trying to help him, try to call some people to help him. But in that time, I think he's ready to get there. And he needs somebody to advise him actually, to show him what's the right way, what's the good, what's the next step actually.
Orientation.
He needs it really badly, because sometimes if you give him a few hours or something like that, maybe he's feeling the bad because he needs somebody to advise him. Our work is not only to get the consent, get organ. Sometimes we're helping the people. I remember there is a story, there is two guys, they never ever speaking together. They are a family, one family. The husband and wife, they divorce and the son is died. We're coming to ask him, they are angry, since 15 years ago. When we're talking to them, alhamdulillah, they get back the relation because they are in bad situation. So our work is not only to get the organ, we are also social people. So we have to advise the people, and this is the humanity. Thanks.
These are very, very good words for the end of this session. Thank you. Thank you for this session.
Okay, thank you very much. Excuse me. There is opening ceremony will start at 7 o'clock with 2 lectures. One for the international speaker, Dr. Delmenico, and also for Dr. Zuhair Qawi, who spoke to you this morning. And after that, complete with the other rituals of the ceremony. Please leave the voting bags on the table. Don't take them with you because they are not going to be beneficial at home. Okay? Thank you for attendance. We enjoyed it. I hope that you did. And hoping to meet you again on other occasions. Thank you very much.